Ahora sí, buenas tardes. Estamos esperando la llegada del doctor Ege Can, de manera que la charla de él está programada para las 2:20. Le rogamos no ausentarse. ¿Ya está aquí? Doctor Ege Can, estábamos esperándolo. Muchas gracias.
Expecting my name appear, and it was a bit late, early.
Yes, it's a little early.
That's okay.
Okay, thank you very much.
Thank you so much.
Thank you.
Dear ladies and gentlemen, good afternoon, and thanks for staying here with us. Apologies, I was not expecting to be here that early, but to be early is better than to be late. So in the next 30 minutes, I would like to talk about the recent advances in ejaculatory disorders, and I will specifically focus on delayed ejaculation and premature ejaculation. After a brief introduction, I will talk about the definitions and classifications that we have recently developed, and then I will talk about delayed ejaculation, which will be followed by premature ejaculation. Let's talk about some basic knowledge. Ejaculation is the expulsion of semen from the meatus of the urethra, and it is constituted by two phases. Phase 1 is the emission phase, and it's the ejection of semen into the posterior urethra, and it involves the contraction of testes, epididymis, vas deferens, seminal vesicles, and the prostate. The second phase, expulsion, is the ejection of sperm from the urethra, and it is believed that it's a reflex response to the presence of semen in the bulbous urethra. And it involves the rhythmic contractions of perineal muscles, namely bulbospongiosus and ischiocavernosus muscles. In this video, the physiology of ejaculation is beautifully presented. When we face with a sexual stimuli, the nerves going up to the brain and then coming back to the spinal cord triggers the reflex of ejaculation. As I just said, in the first phase, which is emission, you can see the contraction of the prostate, seminal vesicles, and etc., and which results in the collection of semen in the prostatic urethra. And this triggers the second phase, expulsion. And during this phase, we detect contractions of the bulbospongiosus muscle, and these contractions are very, very strong, 8 to 11 times, which increases the intraurethral pressure. And after the closure of the bladder neck, ejaculation happens, which is associated with orgasm. Okay, what are the definitions and classifications related to ejaculatory disorders? Well, ejaculatory dysfunctions are recognized as the most common form of male sexual dysfunction, and as I said in the morning, it creates a kind of continuum. At one hand, we have premature ejaculation, and then we have delayed ejaculation, and we have complete lack of ejaculation, which is known as unejaculation, and also we have retrograde ejaculation and painful ejaculation. On the other hand, we have chronological classification, as these problems can be primary, in other words, lifelong, meaning that a man can experience these problems from the very first intercourse and with almost all couples, or they can develop these problems later in their lives, which is secondary or acquired ejaculatory dysfunctions. But what is the normal time of ejaculation? How we should name someone as premature ejaculation or delayed ejaculation person? I really like this cartoon because actually someone from Netherlands asked this question. Okay, early for whom or delayed for whom? For what? What is the norm of ejaculation? And Dr. Marcel Woldinger from the Netherlands actually distributed stopwatches to 5 countries, including mine, and he demonstrated that the majority of men are ejaculating between 4 to 10 minutes, and the median ejaculation time is 5.4. Sadly, my country did the worst score. it was statistically significantly lower than all those countries, and that's why I decided to work on this topic. And 2% of the population were ejaculating lesser than 1 minute, and 2% of the population were ejaculating more than 20 minutes. So we have some sort of data according to the norm of ejaculation time. And as I said, premature ejaculation is lesser than 1 to 2 minutes. Then we have normal ejaculation time, we have delayed ejaculation time, and we have unejaculation. Let's start with delayed ejaculation. There are many, many names for this problem, such as retarded ejaculation, inhibited ejaculation, inadequate or difficult ejaculations, and etc. No matter how we name it, it's the least common, least studied, and therefore least understood male sexual dysfunction. But it is associated with diminished sexual satisfaction for both men and partner. And several organizations tried to define what this problem is. At the upper part, you can see American Psychiatric Association's DSM-5, and then you can see World Health Organization definitions. If you trust me, all these definitions are underlining that these men should have this problem on almost all occasions, and they are supposed to have marked delayed in ejaculation, and this problem should cause clinically significant distress in them. But these definitions are not evidence-based, they are excessively vague, and therefore they lack specific operational criteria regarding their severity, their duration, and the ejaculation time criterion. Therefore, the diagnosis of delayed ejaculation relies on the subjective judgment of the diagnostician. However, considering the fact that most sexually functional men ejaculate within 4 to 10 minutes, we can assume that a man with delayed ejaculation should have an IELT greater than 20 minutes. They are expected to cease sexual activity due to exhaustion or irritation. They should report relationship distress, frustration, or performance anxiety. And most importantly, they need to seek help for this sexual dissatisfaction. We don't know the actual prevalence of the delayed ejaculation, but we assume that it can be lesser than 5% in the sexually active male population. But we know that this problem is more common among older men due to neuronal degeneration, hypogonadism, dermal atrophy, or low penile sensitivity, or loss of pelvic floor muscle tone. However, we also know that this problem is increasing. Today in our clinics, we see more men with this problem because now we have a medication, PDE5 inhibitors, which perfectly restore erections, but it doesn't restore ejaculation, and therefore many men are coming with the complaint of delayed ejaculation. It's more severe and common among men with LOTS, independent of age. We can classify this problem as lifelong or acquired or global, situational, and intermittent. Some animal studies actually demonstrated that there might be some sort of genetic influence on delayed ejaculation. Some PET scan studies, beautiful functional anatomy studies, demonstrated that these men with delayed ejaculation, have higher activity in the anterior temporal lobe of their brain, which are centers for vigilance and fear behavior. What are the causes of delayed ejaculation? Well, classically, psychogenic factors are thought to be responsible for this problem: fear, anxiety, relationship difficulties, religion, culture, insufficient sexual stimulation, and most importantly, masturbation. Our masturbation habit is thought to be responsible for delayed ejaculation. Some studies demonstrated that men who are diagnosed with delayed ejaculation report increased frequency of masturbation, and some of them reported idiosyncratic style of masturbation. I mean, they have a very specific speed, pressure, duration, and intensity which is necessary to ejaculate. And disparity between the reality of sex with the partner and the use of sexual fantasy during masturbation may be responsible for delayed ejaculation. Anatomic causes such as prostate surgeries or congenital problems or neurogenital issues such as diabetes, which cause autonomic neuropathy, spinal cord injury, radical prostatectomy, sympathectomy, and para-aortic lymphadenectomy may cause delayed ejaculation. Infections, endocrine problems, especially hypothyroidism and hypogonadism, may be responsible for delayed ejaculation. And some medications, especially SSRIs, may cause delayed ejaculation, and actually that's why we are using those medications for the treatment of premature ejaculation. Okay, how we're going to approach to a man who complains of delayed ejaculation. First, we need to find potential physical and specific psychological cause for DE, and we need to identify any concomitant or contributory organic factors involved. You can check life events and circumstances related to orgasmic cessation. You can review the conditions under which the man is able to ejaculate, and you can investigate domains related to the psychological and relationship issues associated with delayed ejaculation problem. Of course, after history taking, we need to perform physical examination and run laboratory tests. Sadly, these are rarely diagnostic. We can examine penis, testicles, epididymis, vas deferens, and if we are lucky, we can identify some urethral, prostatic, epididymal, and testicular infections. And sometimes we can observe penile irritation and erythema due to the idiosyncratic masturbation habit. We can run lab tests such as fasting glucose level, testosterone, thyroid hormones, or PSA. Imaging studies can be performed, but they will not give you any clue about the cause of the disease in the majority of cases. And you can run electrophysiological evaluation if you are really into this problem and if you are conducting some researches on delayed ejaculation. What is the treatment? Well, if a medication is causing, such as antidepressants, causing delayed ejaculation, you can reduce the dose or use antidote. If there is vascular or neuropathic damage, sadly, these are irreversible, and the patient should receive some sort of psychological counseling. If there are infections, treat the infections. If you detect androgen deficiency, you can put the patient under testosterone replacement therapy. And if there is hypothyroidism, again, you can give thyroid hormone to the patient. In addition to that, if you can suggest patient to have some lifestyle changes, such as reducing alcohol consumption, making love when they are not tired, and decreasing the frequency of masturbation. Psychotherapy is the classical treatment of delayed ejaculation, but we don't really have a lot of articles, evidence-based articles on that issue. Sex education therapy, reduction of goal-focused anxiety, genitally focused stimulation, role-playing, desensitizing exercises are all taught to be effective in the treatment of delayed ejaculation, but we don't know much about that. Again, experimentally, we can use pharmacotherapy, but sadly, we don't have any placebo-controlled studies, but serotonergic drugs such as desipramine, cyproheptadine, buspirone, mianserin, nefazedone, or dopaminergic drugs such as L-Dopa, amantadine, yohimbine, and bupropion may treat your patient who suffer from delayed ejaculation. So in conclusion, delayed ejaculation is the less common, less studied, and less understood ejaculation disorder, especially compared to premature ejaculation. Currently, authority-based definitions are vague, multi-interpretable, and lack specific operational criteria. Etiology is multifactorial, and physical examination and lab studies are rarely diagnostic. If possible, treat the organic cause first, but if not, you can do psychotherapy or you can try one of these experimental medications. Okay, now the hot topic, premature ejaculation. unlike delayed ejaculation, premature ejaculation is very common. Several studies demonstrated that it may affect up to 30% of the population, and therefore it is cited as the most common form of male sexual dysfunction. And it causes important psychological problems such as diminished self-esteem, anxiety, embarrassment, and relationship problems. Similar to delayed ejaculation, we didn't have an evidence-based definition for premature ejaculation for so many years, but fortunately in 2014 we have developed a definition for that. According to this definition, premature ejaculation is a male sexual dysfunction characterized by ejaculation which always or nearly always occurs before or within about 1 minute of vaginal penetration from the first sexual experiences. This is accurate for lifelong PE, or a clinically significant and bothersome reduction in latency time, often to about 3 minutes or less, and this is for acquired PE. Inability to delay ejaculation on all or nearly all vaginal penetrations, and negative personal consequences such as distress, bother, frustration, and or the avoidance of sexual intimacy. We were very happy, we were very proud for developing this definition, and we have published this article in JSM, and then we were not able to make any recommendations for men who complain about their ejaculation time, but who do not fit to this definition, such as we are seeing some men who came and look for their premature ejaculation problem, but they ejaculate later than 3 minutes, or some of them say, I ejaculate fast sometimes, but sometimes I'm completely normal, but I want treatment for that. So we didn't know how to approach to these men. But again, Marcel Waldinger, the Dutch guy, came up with a solution. He said that we should not regard PE as a syndrome, we should consider PE as a complaint. And here are the PE syndromes that I suggest. We have lifelong and acquired PE, which are already covered, and also he suggested the presence of 2 additional PE syndromes, such as variable PE and subjective PE. Well, I have just made the definition of lifelong and acquired PE, and in addition to that, we have variable PE. These men have normal IELT. This must be considered as a normal variation of sexual behavior, because sometimes whenever a man is so excited or whenever a man did not make sex for a long period of time, they may ejaculate early. Therefore, reassurance and sexual coaching may be the treatment of choice for this kind of people, and its prevalence is high. And the other syndrome, subjective PE, these men have normal or sometimes long IELTs, ejaculation times. This is a kind of psychological problem. This is not a really biological disease. So psychotherapy must be applied to those people, and its prevalence is thought to be very high. In an epidemiologic study we conducted in Turkey, we have demonstrated that 20% of the population, of the sexually active male population, were not happy with their time to ejaculation, and when we check their complaints, we saw that the majority of them are actually defining subjective PE and variable PE, whereas only 30% of them describing lifelong and acquired PE. But when we look into the data that we collected in our sexual medicine clinic, we have demonstrated that the majority of men who are coming to your outpatient clinic are actually suffering from lifelong PE and acquired PE. So there's a discrepancy between the population and outpatient clinics. Several factors may play a role in the etiology of PE. Psychogenic issues such as sexual abuse and attitudes towards sex internalized during childhood, individual psychological factors, and relationship issues may cause premature ejaculation. Urological problems such as erectile dysfunction, prostatitis, or chronic pelvic pain syndrome may be associated with early ejaculations. Neurological problems such as hypersensitivity of the glans penis, increased cortical representation of the pudendal nerve, disturbances in the central serotonin neurotransmission, and genetical factors may be responsible for PE. Thyroid disorders, especially hyperthyroidism, is demonstrated to be a factor in the presence of premature ejaculation. Recreational drugs, detoxification from medications, especially antidepressants, may result in PE. So here are the etiological factors of PE, but don't forget that none of these etiological factors have been confirmed in large-scale studies. How to approach to a man with PE? Well, we should start with history, as always, and these are the questions that we are expected to ask, and these are the questions which I mostly use. What is the time between penetration and ejaculation? When did you first experience premature ejaculation? Is your erection hard enough to penetrate? Just to elucidate whether the patient is suffering from erectile dysfunction as well. And have you received any treatments for your premature ejaculation previously? If the patient is describing subjective and variable PE, you can refer him directly to a psychiatrist or a psychologist. But if the patient is describing lifelong or acquired PE, then he is your patient, and you should either apply medical treatment or psychological treatment in combination with medical therapy. Well, over the past 20 to 30 years, the PE treatment paradigm has shifted from psychotherapy to drug treatment, and today we are commonly using antidepressants, topical anesthetic, tramadol, and many other medications for the treatment of premature ejaculation. In Europe, we have one drug which is specifically developed for the treatment of PE. This is dapoxetin, and it's the first compound specifically developed for the treatment of PE. What makes this molecule very unique is its rapid absorption and rapid elimination, unlike other SSRIs, which stay in the body for so many hours. So, and it's the only approved medication for the treatment of premature ejaculation. Numerous studies demonstrated that the on-demand dapoxetin treatment is associated with improved ejaculation time, and also patients who are taking dapoxetin are describing better control over ejaculation. They are having less personal distress related to ejaculation, and they are very happy for using this drug. However, when these studies are done by pharmaceutical companies, but when we conduct post-marketing studies, we saw that the vast majority of patients do not like to get medications for delaying their ejaculation time, and the ones who use those medications quit the treatment at the end of 1 year, no matter whether they are effective or no. So reasons for the treatment non-acceptance and discontinuation are effect below expectation, the cost of the medication, side effects, and loss of interest in sex, and some of the patients reported no efficacy. Okay, that was dapoxetin. What are other treatment options for the treatment of PE? Well, on-demand topical anesthetics are the first described. In fact, in 1954, this treatment have been described. Lidocaine plus prilocaine containing sprays, gels are being used for the treatment of PE. There are few controlled studies, and they are moderately effective. However, they have potential risk of penile hypoanesthesia, and it can go to the vagina of the female and result in vaginal numbness and female anorgasmia. However, today guidelines recommend this treatment for PE. Okay, in addition to dapoxetine and then topical anesthetics, what else we have? We have tramadol, which is an oral centrally acting opioid analgesic indicated for the treatment of moderate to severe pain. Its efficacy in the treatment of PE have been reported. The mode of action is unclear, but it's not recommended due to the risk of addiction. There are several other molecules in the pipeline. One of them is DA8031. This medication is developed by our Korean colleagues. And in the beginning, they have demonstrated that this medication is associated with significant delayed ejaculation in rats. And they have published their papers in esteemed journals, and currently they are conducting their clinical trial. The second agent in the pipeline is Tempe. Unlike topical anesthetic gels, this is a spray, and the authors claim that this spray is associated with a shorter action, and the patient can use it without transferring the molecule into the vagina of the partner. This is a molecule that I initially published, modafinil. Modafinil is a wake-promoting agent, and it is used for the treatment of narcolepsy, and its exact mechanism for its stimulatory effect are still to be determined. But catecholamine and indolamine pathways, including dopamine and serotonin, are probably involved. In an animal study performed by our American colleagues, it has been demonstrated that on-demand modafinil administration is associated with a delay in ejaculation in male rats, and the greatest delay in ejaculation was observed in animals with shorter baseline ejaculatory latency. Considering these promising findings in that animal study, I started to administer this medication to my PE patients who are not very happy with the currently available treatment options. And we have published a case report demonstrating the efficacy. And then we conducted a clinical trial on 55 lifelong premature ejaculation patients. And also we demonstrated that on-demand modafinil 100 milligram treatment increased the mean IELT, mean ejaculation time, and it is associated with improved premature ejaculation profile questionnaire outcomes. Another option is daily alpha-1 blockers. Ejaculation is a sympathetic spinal cord reflex which could theoretically be delayed by alpha adrenoreceptor blockers. Several authors have reported their experience with the selective alpha-1 blockers, such as alfuzosin and terazosin, in the treatment of PE, but current data is a bit confusing and conflicting. This paper is coming from Japan, and our Japanese colleagues demonstrated that silodosin is associated with a significant delay in ejaculation, and also the patients are very happy to use silodosin for the treatment of their premature ejaculation problems. And they have demonstrated that when the patients are having silodosin, they are reporting better ejaculation control, better satisfaction with intercourse, and lesser personal distress. In a study where the authors compared several alpha blockers, they demonstrated that silodosin exerts the strongest ejaculation delay time compared to tamsulosin, alfuzosin, terazosin, and doxazosin. Another agent is oral oxytocin receptor antagonist, epelsiban. Oxytocin is an interesting molecule that we were constantly neglecting for so many years. It plays a role in ejaculation. When you administer oxytocin systemically, it reduces latency time to ejaculation, and it increases the number of sperm per ejaculate, especially in rabbits. Ejaculatory delay observed with SSRIs may be mediated through the alterations of central oxytocin release, and ejaculatory inhibition of SSRIs was reversed by oxytocin. Therefore, oxytocin release increases during sexual arousal and followed by a marked increase at ejaculation in humans, bulls, rams, and rabbits. Considering these facts, American group conducted a double-blind, controlled, randomized study in 77 lifelong premature ejaculation patients, and they demonstrated that apelsiban, which is an oxytocin agonist, is associated with, oxytocin antagonist is associated with improvement in PE symptoms. And this is the official website, and their clinical trial is currently going on. This is another treatment that I have been explained, botulinum toxin injection for the treatment of premature ejaculation. You remember that the contractions which I showed in the beginning of my presentation, bulbospongiose contractions. So I hypothesized that if we inhibit these contractions with the injections of botulinum toxin, we may delay ejaculation. Actually, we have tested my theory when I was in the United States on rats, and we have demonstrated that these are the bulbospongiose muscles in rats. And when we inject Botox to these muscles, we have demonstrated that there's a significant increase in the ejaculation time of rats. Considering these promising results, the Allergan company, which produces Botox at that time, initiated their clinical trial, and this clinical trial is at the moment going on. In conclusion, the neurochemical control of ejaculation is complex and incompletely understood. Multiple neurotransmitters and neuromodulators and receptors are involved at multiple levels of the nervous system. Much remains to be learned with regards to the mechanisms of pathophysiology and management options for PE. The new ISSM Unified Evidence-Based Definition of PE, produced in 2014, could be a critical step in improving our understanding of the scope and process of this disorder. Further studies are required to learn more about variable and subjective PE. Current medical therapy offers several effective options, with many more in development and trial. Continued research will identify mechanisms which control ejaculation and serve to identify new therapeutic targets for PE. Before concluding my words, I would like to invite all of you to our exam in Europe that we do. This is an exam to be certified as a fellow of sexual medicine, and this examination will be conducted in 28th of February 2018 in Lisbon, and you are more than welcome to come to that examination and become fellow of sexual medicine. Thank you so much.